She has in 2004-2005 and EC member of IES and ISPRP. She has been in organization team of IICD National Conference in 2000, PG Convention 2007, and second zonal conference held at Mangalore in 2019. So we welcome you, madam, and I now request Dr. Kundabala, madam, to introduce our distinguished speaker for today, Dr. Jayshree Hegde. Over to you, Kundabala, madam.
Am I audible?
Yes, ma'am.
Okay. A very good morning to organizing team led by Dr. Pratima Shenoy. That is this webinar, E-Link Fest 2020 from VSPM DCRC Nagpur. And Dr. Jayshree Hegde Anil, the beautiful speaker of today, and all the participants of this webinar. First of all, I would like to thank Dr. Pratima Shenoy and her team for inviting me as a part of this program. And I appreciate, at the outset, I appreciate the organizing team for organizing such a mammoth task with galaxy of eminent speakers from all over India, especially at this tough time. So, and today we have our beautiful speaker with a beautiful smile speaking on beautiful, creating beautiful topic, creating a beautiful smile line, restorative perspective. Dr. Jayshree Hegde Anil graduated with Bachelor of Dentistry from GDC Bangalore and then post-graduation from the same college. She started her teaching career in 1996 and involved with the PG training from 2002. And she was heading the department at Oxford Dental College Hospital, Bangalore, from 2009 to 2013. And she was involved with the academic activities during this period. And during this period, whoever has done PG are really appreciating her, because I've seen it in many conferences that all of them come and, you know, appreciate her a lot. So she quit academics, unfortunately, in 2013 and joined as a clinical director at Ridgetop Dental International at Bangalore, India, involved in group practice that provides advanced dental services in the field of aesthetics, microdentistry, and implant. She has got several publications in indexed journal to her credit. She's a member of Indian Association of Conservative Dentistry and Endodontics, American Academy of Cosmetic Dentistry, Indian Academy of Aesthetic and Cosmetic Dentistry, Indian Dental Association, and Vice President of Indian Board of Micro, Restorative, and Endodontics. She has a vast experience in microscopic endodontics, smile makeovers, and full mouth rehabilitations. She has delivered lectures in national and international forums and authored 2 books, Prep Manual in Endodontics and Concise Conservative Dentistry and Endodontics, published by Elsevier Publication. We have to thank Ms. Sushmita Sen and Aishwarya Rai, who created awareness in smile designing. What our forefathers used to do, or our predecessors in dentistry used to do, is they used to just make over the functional dentition, ignoring the global aesthetics involving smile. So aesthetic dentistry has come long way, and we have to give credit to the newer generation of dentists who are concentrating on not only functional aesthetics, but aesthetics as well as the function, form, function, aesthetic, and overall personality of the patient, and improve the confidence of the patient. So today we have learned how to do integrated multidisciplinary dentistry along with orthodontists, periodontics, periodontists and restorative dentists to customize the smiles of our patients. So in this webinar, Dr. Jayshree Hegde giving her vast experience on how to achieve the functionally successful customized smile by integrating art and science in restorative dentistry, and she'll be sharing her clinical experience basically. And I'm sure it will be a great feast for all our participants, because she'll be sharing her personal experience. It is not like from textbook or anything. So a lot of her cases she'll be presenting, and all of us, I think all the participants will enjoy this program. I'm sure it will be a great experience for all of us. Yeah. Thank you, and over to Dr. Jayshree Hegde Anil.
Madam, mic.
Thank you, Dr. Kunda, for your very, very generous introduction. I've been Dr. Kunda's junior throughout, and I have learned a lot from her. I've learned a lot from my seniors and all my colleagues who have been with me, either in academics or out of academics. Today, I have to first thank Dr. Pratima Shenoy and her team for giving me this opportunity to share my clinical experience in aesthetic dentistry. Aesthetic dentistry has gained popularity since the past 2.5 decades. As Dr. Kunda rightly said, we have moved from practicing white aesthetics to natural aesthetics. With advancements in materials and techniques, we are able to achieve aesthetics that closely mimic the natural dentition. After being in academics for the past 15 years, I understand the research team gives you so much data to work on in the clinical scenario. Today, after being in this totally a clinical setup, I have given up academics as per definition, but I still give lectures and it's part of academics for me. And what I'm going to do is I'm going to share my clinical experience in aesthetic dentistry, what to do and what not to do, so that you get a long-term predictable success. It's not enough if the teeth looks very good in the anterior segment as soon as you do it, but how does it work? How does it function over a period of time? So we have patients who come to you with varying requirements. You have patients coming to you with spacing, unaesthetic restorations, reverse smiles, poor visibility, and wound dentition. Of course, most dangerous for us to do is a wound dentition, which has different reasons and etiology for it to reach that particular stage. If you look at this teeth on the lower right side, you see that the wound dentition has a pattern which almost is similar to that of the upper wound pattern is almost similar to that of the lower pattern. So it's almost parallel, and you need to first find out what is the etiology. But to start with, we can start with simple cases like spacings, and you can see this teeth which has got PFM crowns, which is very, very unaesthetic. These are all simple cases that we can all start with. Whatever be the reason, our main goal is to build a long-term, stable, functional smile where the patient is very confident to show off their smile. In all our practices, maybe just a small composite restoration or any other kind of aesthetic restorations, when you place it in the anterior segment, the confidence of the patients leaps, and hence the patient is always happy. So that's our main goal, that we need to improve the confidence of our patients. So what is so important? The first step in any aesthetic treatment planning is interview, aesthetic interview. We need to just get the patient in a room. You should not have too many attendants in that room. You should be just you and the patient. So the patient is not conscious, and they start opening up and they tell you what is required by them. Even when we take some videos, the patients are very, very conscious, and you may not get the complete data of what you want. It's always good to have an aesthetic interview. So what you get from this aesthetic interview is, what does the patient like about her smile and what she does not? What is her expectation? Can we give her what she wants? And it's always good to set the expectation right at this interview itself. Do not promise things that you cannot deliver. You have to set their expectation right. And you have to bring in all the interdisciplinary aspects that is required. In the case the patient does not approve of any of the interdisciplinary dentistry, then it becomes difficult to achieve what you want to achieve, and it is good for us to set the patient's expectation right. So you do a thorough examination and collect all the data and share this data with the patient, and video capturing has to be done so that we can go back to it and recollect all what we have captured during the interview. So we have different levels of aesthetics: facial aesthetics, orofacial aesthetics, oral aesthetics, gingival aesthetics, and dental aesthetics, which include both micro and macro. Within the purview of this time, I will take over from oral aesthetics to dental aesthetics, which is much more under our control. So first, in oral aesthetics, we need to see the relationship of the lip to the gingival tissue. At rest, you see the lip is at rest, and you see the amount of teeth display in this image. But when the patient is smiling, you can see how the lip moves. Some of the patients have very less lip movement. Some of them don't show any teeth at all. Some of them have very high lip movement. Those who don't show the lip movement, show too much of teeth, it's easier. We can hide all our faults under the lip. But those who show medium smile line to high smile line, we need to be very, very specific as to what needs to be delivered. So if you look at this image, you see there are, the smile looks very nice when the lip is at rest, but when they're smiling, you can see certain deficiencies. You can see that in this area, the gingival lines are at different levels, whereas in the lower one, you can see the gingival lines are very good, but there is more of gingival display. So there is maxillary excess over there. You also see in elderly patients, when you're dealing with elderly patients, you see more of the lower teeth than the upper teeth. So you need to be conscious about how you place the lower anterior levels of aesthetics or levels of occlusion. Your teeth needs to be at least 2 millimeters will be visible, and hence we need to make sure that the alignment is good. Most of the patients who come to us, especially the young patients, though we give them a plan for upper and lower, they can still get away with just the upper because only upper teeth are visible, and they would generally want to get the lower teeth done at the later stage. But for the elderly patients, the lower teeth plays a lot of role, or it is very critical, because the elasticity of the lip reduces, and hence the lesser amount of teeth is visible, as the upper lip does not move as much as in the younger patients, and the lower teeth droops down. So there is more visibility in the lower teeth. You should also look into the lip symmetry. If you look at these two images, the upper image, even when the patient is at rest, you can see how the lip positions itself on the patient's left side, whereas in the lower, you can see that the entire lip symmetry is not good. It is asymmetrical. So the visibility of the teeth also the lip has a big role to play in the visibility of the teeth. Especially in this, you can see more teeth on the right than on the left side of the patient. Next is how the teeth sits on the lip. So we take a 12 o'clock position photograph and we see how the edge of the incisal edge of the teeth sits on the vermilion border. So you see here, you can see only 2 teeth here. So that means we need to get the teeth out, the remaining and where is it in. So this 12 photograph gives the information we use. Next is the oral aesthetics. We have the buccal corridor. Most of us like play with buccal corridor. Have a buccal corridor like this, where the 2 premolars that are tucked in, the molars are in the right position. Then you have teeth like this, where you have absolutely no negative space at all. And then you have teeth like this. Though in the past, we would love to cover the buccal corridor, we don't want any negative space. But from my experience, I see more patients don't like yes, they don't like the teeth, they smile, they don't have a little of teeth, like this kind of little bit of negative space over here. They do not approve of these. So that's my experience. Of course, each patient, it's a very subjective thing, but during your trial, your smile makeover trials, you need to make sure, you need to point out those things before you go in for your final restorations. So my experience is you need to have some amount of negative space, but not too much. The position of the gingival, the height of the gingiva is very, very critical too, to give you that shape of the gingiva. So if you look at this image again, you see that it's in different levels. So we need to slightly increase or do some crown lengthening procedures or orthodontically move the teeth to get very good position. So whenever the patients put through orthodontic treatment, when we end, followed by veneers, we always ask the orthodontist to take a note on the gingival margins instead of the incisal edges, because it's very critical to get the gingival margins in alignment, as the incisal edges can always be played around with while you're placing veneers. Then you have teeth like this, where the gingival condition is so poor. This is a patient who wanted aesthetic correction. So it took us almost 8 months to 10 months to get the tissue very, very we went ahead and did good gingival therapy, and we reduced the length of the tooth. And this patient is an elderly patient. You can tell that with the image itself. There was less amount of teeth visibility, so the lip movement is not, so we could hide and the lower was. So what I like to do is do not do any kind of aesthetic without taking care of the soft tissue. Soft tissue has to be very good, very firm, and it gives you a lot of predictability. If you don't have very good tissue, once you do your aesthetic treatment over a period of time, there could be recessions, there could be margin display. So it's very, very important to get your gingival tissues in place in a healthy actually scheme of treatment. That's my take on that. So what I would always think is 65% to 70 to 80%, 75 to 80% is a good proportion to have. Now, if you look at these images, you can see that the first image over here shows that it is 100%. It's always almost like a box. It's a square. And then comes this 85%, which also is like a square. It's generally seen in patients who have some wear. And you have 65%, which looks very long. And that's the proportion between the length of the tooth and the width of the tooth. So we always like to keep it at 70%, 70 to 80%. And if you look at this image, your width of the anteriors generally fall between 8 mm and 8.2, 8.5 mm. So you have a fixed width. You need to play around the length of, and if the length during smile. So you cannot say that 8 mm is the tooth and now I'm going to give the length as 10 mm. If the 10 mm is not visible, then you will have to probably go for 11 mm or 11.5 mm. So it is subjective again, and again, the width of the tooth also depends on how much of spacing is created between the canine to canine, and you get a good balance. So it all depends on, you cannot put in a proportion depending on what we have learned earlier, like golden proportion, red proportion. We need to do it subjectively for each patient depending on the width that you want to create and the length that you want to, depending on the visibility during smile. So then comes the contact area. Now the teeth can look smaller or larger depending on the contact area. And this contact area again is dictated by the papilla. Now, if you look at the first image, you have a very short papilla here, a short contact point, and you have a larger papilla that goes all the way almost towards the middle third of the tooth. And then you have the next image over here. You have the papilla that is almost at the cervical third of the tooth. And this image on this, on your right, shows that it's almost towards the incisal edge. So when you change the papilla position, the patient will suddenly feel that the tooth is looking too odd and too broad. And that's what happened with this patient whom you see on the right. We changed the papilla position. We gave the temporary crowns after doing a little gingival periodontal therapy. And suddenly the patient said that the tooth is looking too long. And in fact, we didn't change too much of the tooth length and size, but it's the papilla position that we changed, and that gave the feeling that the tooth is too long. So the position of the papilla also plays a major role. And I would definitely recommend that you see the positioning of the papilla to make sure that the tooth does not look too long. So collecting all the data from the patients, then we try to do a treatment plan. We do a treatment plan which gives you a very balanced smile. So what is that we need to see here? We need to see the aesthetics. We need to see what is the occlusion, the type of restorations that you need to give, and if there is any kind of interdisciplinary treatment. In the aesthetics, like how we already discussed now, it's the length. We look into the length. I look into the shape, the color, the shape which is varying, the color. Some of your patients will tell you they want nice white teeth. You don't know what is white. You give them a shade guide, and some like bleach and beyond bleach. And some of them don't want that bleached look. They want a natural look. And some of them who have an 8.3.5 shade would like to go back to 8.3.5 shade because they don't want a drastic change, especially in the older or the elderly patients. So, and then you see the alignment and the texture. Now the texture, though I won't go too much into details, some of them like it glossed. Some of them like it textured. Now, as a dentist, I like the veneers to be textured because when we do our composite restorations, we try to give textures in the restoration. And again, in veneers, when we have a chance to do the texturing, we should always look into a mild textured veneer, which will give you a very, very natural look. Then you have the occlusion. Now, when do we change occlusion? How is the molar relation? That's what we need to assess. The type of restoration, should we go for veneers? Should we go for crowns, composites? You have ceramic or you have zirconia. That's the translucent zirconia, which can also fit in your frame in the anterior segment. So today I will be discussing more on the ceramic. I won't touch on these, and I can definitely tell you what goes for veneers and what goes for crown. It all depends on what is the type of substrate that you have. If you have very good enamel and your positioning of the teeth, it depends on the position of the teeth. And if you have good enamel, I would always think veneer for me is the best option for the anterior segment. Interdisciplinary, you have endo, perio, surgery, and ortho, which is always a part. Endo, perio, and ortho is most often a part of our aesthetic treatment. And as I said, we are in a group practice where all my doctors are full-time doctors. So all the patients who come in there go through a perio evaluation, an ortho evaluation, and a restorative and an endo evaluation. So if you look at this patient, if a patient like this comes to your practice with a reverse smile, and if you actually see the retracted view, she has a good length in her anterior teeth, but her lip mobility is not so good. It's a low lip line. So she wants to get her smile better. So what you do is, in that case, when you send this photo to the lab and a model, probably your ceramist will not know what is the amount that he has to increase. So what we do is we draw the line and we build it up with composite restoration. So the anterior centrals, build up the anteriors with composite restorations, get the patient to smile. And if you like the smile line, you can reduce, you can increase. Don't etch the tooth, just do a nice bond and do a composite restoration so that you can flick it off before the patient leaves. And then you build up the laterals. Once you do this, after you build up the centrals, you can take impression, or you can take a photograph and send it to the lab, or you can use a perio probe to indicate what is the amount of addition you want in the incisal edge. Then you choose the shape. You have, I'm sure whoever is doing aesthetic dentistry, you will have so many photographs in your album. You can pick and choose all the nice looking teeth. You can make a small album of that, and then you can show it to the patient. What is that they like? What you like, the patients may not like. You are always looking at 75% as your proportion for the central incisor. But sometimes the patient likes the overlapped incisor. Sometimes the patient likes a longer incisor and a shorter lateral. I would always look at laterals. Centrals, we have certain data. Even what I think is the shape of the centrals mainly depends not on the length, not on the breadth. You have your gingival tissue, which dictates the shape on the gingival side. You have the incisal edge. Slight curving of the incisal edges or the angles makes a big difference to the patient. So when you have your temporaries, I always get it squared. Then I slowly take my disc and adjust the edges, the angles of the tooth, and the line angles of the tooth. Those are the ones which actually give you the shape, and you can make a big difference with just altering these fine points. For me, laterals are very, very important. Laterals play a crucial role in aesthetics. If you look at these laterals, different kinds of laterals, you have a lateral here, which is very flat. And then you have lateral here, which almost closed embrasure, again, flat. Then you have a lateral, which is very nice and delicate over here. So you have, most of the times you see the laterals have a different kind of shape. As the patient ages, it becomes flat, but in young people, you have a nice delicate, the lateral is the one which gives you a very nice delicate look to the smile. So pay attention to the laterals, and though the patients probably won't know what looks good to them, you can always get a flat lateral, just like this. And then during your smile evaluation, you can make a lot of modifications during the smile trial, and that gives the patient, they will see the changes. That's one way of doing it. Another way of doing it is you ask your lab guy to give you on one side a particular shape, on the other side, with keeping the centrals as it is. You keep the other side, you ask them to give you a delicate look, and then the patients will tell you that they like the left side better than the right, and then you can ask your ceramist to accordingly make the changes or replicate one side. So it's mandatory that you all take face bow. You have to do a face bow transfer and articulate the models and then send it to the lab. Then you send the design, plan, and data. you should have a very good relationship with your ceramist. You cannot get angry with your ceramist. You have to work along with, he's your part of your team, and you need to specify what he wants, because he cannot see what you can see. So you must specify every detail as to what the patient wants, and then you send him certain videos and photographs to help him fabricate the the veneers. So once he fabricates the veneers or the wax up, this is how the model will come back. You may need to see how the anterior guidance is set. If you're doing only veneers in the upper anteriors, you will probably not change the palatal aspects, but you still need to see how your centrals sit together. The centrals, when they come in contact with the, when they are at edge to edge, you cannot have a single central incisor touching the tooth. It has to be all the three, all the four touching in a flat plane at different time. You can also get a digital wax up done like this, which is digital wax up, the printed model, and then you can also get ask your ceramist to share the digital wax up. This is an ExoCAD which my ceramist uses, and you can see how the wax up is done in this model. And if there is a patient like this who has midline shift, she has missing right laterals, that is 1, 2, and you can see there are peg laterals on the left side, and the entire central, upper central segment is shifted, and she has a missing central incisor in the lower. So in this case, what we do, we send it to the patient. So to the lab, and then you ask him to do a wax up before this patient goes in for ortho. So this is a wax up he sends it to you, and you can see, you can measure from the premolar to this waxed up central incisor, that is 1, 1, and you can ask your orthodontist to move the centrals and make sure that it is in alignment with the frenum and the philtrum, and you can see that this is some of the information your lab can send you for better planning. And finally, you finish your ortho and do you place an implant in the 1, 3, it's a missing tooth, and then you place your restorations over here. So once you get your wax up, you which is tucked in on the left side. So this is what I mean when you give the patient a wax up. Some patients like the one on the right side, some patients like it tucked in. So you can decide in the during the wax up and the smile trial itself what kind of canine you want. And in case of this patient, if the patient liked the canine on the right, you can use a little flowable material on your canine on the left and build it up and give a nice smile and get approval from the patient. And this patient didn't want a implant, and that's why we had to go for a bridge there. So in a patient like this, if you look at, you need to evaluate the occlusion in a patient like this. On the right side, you see the patient's main chief concern is discolored teeth, a lot of hypoplastic area, multiple decay, poor oral hygiene. but her molar relation, there is absolutely no wear at all. So the molar is very good. Unlike the one which you see on the right, you see there's no proper occlusion over here. There is worn out teeth in the anteriors, and the posteriors are also worn. In this condition, you need to go for a full mouth rehab, and because the occlusion is very, very unstable here. But here the occlusion is stable. Doesn't matter whether it's class 1, class 2, or class 3, it's still a stable occlusion. You can go ahead with only working on the anterior teeth. Now I'm going to show you some of the cases so that we have 20 minutes more, and I will take you through around 5 cases, and I'll tell you what we did in these cases. So this is a patient who came to us with a nice smile, but there is spacing. What is the advantage of this case? He has very long incisors and narrow incisors, narrow and long. So it's very easy in these cases to just do a space closure, because when we increase the width while we close the diastema, it won't make a big difference because he has long incisors. So we missed out on that slide there. So this is another case. Let me see. I'm going to just take you through that. Sorry about that. For 4 years. Case 2, and that was a very simple case to start with. Now this is a young girl, very pretty smile, undergone orthodontic treatment, but she doesn't like the gummy smile that she has. Though for me, this is acceptable gummy smile, but she did not like the gummy smile. In fact, me and my team totally discouraged her from going for veneers because we thought her teeth are really pretty and she has very good smile, and I would think it is very, very nice and good. So since she didn't want her gums to be visible, so we did a little gingival periodontal treatment. We saw a lot of enamel was tucked in under her soft tissue. So we told her, don't go for veneer. We will do a gums treatment, perio treatment for you, and see if you like it. So this is what we did. We finished her perio treatment, and then this is what. Now she said, I don't like the way the tissue, the papilla between the central incisors are sitting in there. So she said, I want the same length of the teeth, but I don't like the tissue sitting in there. So then we had no other option but to go in for treatment. So we opened it, we cleaned it up, we did some procedure. I reduced the size of the tooth. Luckily, we had enough enamel and dentin over there. So we reduced the size of the tooth during our prep itself. And then we removed the tissue. And she also didn't like the way the shape of the tooth. It was looking more like a triangular shape. And she wanted the same kind of gingival architecture that she had earlier. So you can see we took some nice pictures of the teeth. Sorry. No, I'm sorry. So somehow. So we took some nice pictures of her teeth. We gave her temporaries. We held the tissue in position. And finally, we gave her the veneers. This is 1 week after the veneers were placed. And this is 3 years later. And currently this is her smile. So we achieved what she wanted to achieve, though with some amount of tooth structure from the incisal edges, though the prep, except for the incisal edges, the prep on the teeth were very, very minimal prep, because we kept all the enamel. We gave her very nice thin veneers, except for the incisal edge. Incisal edge we had to decrease because she wanted the length of the teeth, she wanted it at the same level. So she is following up. This is actually a straightforward case, but we took it in a different way. My third case, this is her, sorry. So this is her before and this is her after smile. So our third case is a patient who came with spacing between the teeth. So we had some missing, you can see that there are some missing lateral on the right side. You have 1, 2 is missing. And he has a very, very poor gingival periodontal status. So again, we did a good periotherapy for him. You can see that. And then we gave him a trial smile. And we, again, this patient is slightly elderly patient in his 50s. So you can see visibility of the lower teeth is much more than the upper teeth. And then we started with the upper. Now, one recommendation or one advice is that when you have elderly patients coming in, you should not go in for a very thin veneer, because your dentin could show, and over a period of time, the dentin gets sclerosed and it gets darker, and it could change the color of your veneers. And in the past, we used, I used for all my cases, I've used Veriolink as my cementing resin. And those cementing resins, all the cementing resins that we had earlier in the past contained some amount of amine. The dual cure resins had some amount of amine. But right now we have Veriolink aesthetic, which is amine free, and hence the chances of discoloration due to resin is nullified. So those who are doing aesthetic restorations, I would advise you to choose non-amine resin luting agent. But if you have very, very thin, very thin veneers, you can always use a light curing veneer material, cementing material that will give you a very long lasting color stability. Now you look at this teeth, we finished with the lower two, and what I want you to see is, take a note, is look at the tissue. It has stabilized so well that you can't say that it was so bad in the earlier. So this patient comes to us every 3 to 4 months for his perio treatment, and it's a very, very today. And this is how it looks after in 2020. So we started that case in 2011. And over a period of time, you can see that his tissue has really, really stabilized very well. So health of the periodontal tissues is critical. And this patient is a bruxer. He has sleep apnea. Yet you don't see anything cracking and breaking if the occlusion is set right. So the occlusion is perfect, and the patient doesn't wear any night guard. He does not like to wear any night guard. So in spite of all this, you see how stable your restorations can be. You can't even make out that there is a missing lateral here, and we have converted this canine into lateral, and this is his premolars, which we have converted into canine. And this patient, the previous patient, didn't want to go for orthodontic treatment. So that's why we had to finish this and crowns. Again, you can see that her occlusion is not stable. You can see occlusion is not stable. So, we advised her orthodontic treatment. Initially, she was very reluctant to go for orthodontic treatment, but we told her that that's the only way out. She has to go, otherwise she may not find, we may not get stable occlusion. And when we took our pictures, you can see that she has missing laterals too. And the canines were converted into laterals. And since they were spacing, they fused the crowns. And one piece of advice is you can do PFM crowns in the anterior segment. It is not, it's one of the most unaesthetic crowns that you can get unless you have a lot of tooth cleared out, a lot of teeth trimmed out, and there is enough amount of space for your ceramist to build in a very, very natural aesthetic restorations, which is very, it is not good. So here you can also see that these bone that is there, it's called a washboard appearance. So when an orthodontist will know that he has to be really, really careful when they move the very high in these cases, the amount of bone is very, very less. So we need to be very, very careful when you see these anteriors over here. So my orthodontist did a great job. She did a great job in pushing the teeth, and right now we are waiting for it to stabilize. What I'm trying to tell here is when we remove this bridge that is there, you can see the canines that are there. You this a temporary crown, a final crown that you want to achieve. So this is a temporary crown. This is what she likes. So we give her a temporary crown and ask the orthodontist to move the teeth so that the orthodontist also knows what is the amount of movement that she wants to achieve. Now you can see here, because this tooth had to move into the arch, so we reduce the length of the laterals, but ideally that lateral will definitely come down. Okay, or is a little more complicated case compared to the previous cases. You can see a lot of wear. Now, the most of this wear is not because of, one is the anterior wear is mainly because of the bite that he had, and you can see how tucked the class 2 div 2 is. You can see the anterior is totally tucked in. So we put him under orthodontic treatment. We wanted the anteriors, upper anteriors to come out a little bit. Again, he had, you can see that there is a missing lateral over here. The canine is moved to that space. You have a peg-shaped lateral over here, and you have a missing lateral, which with the canine moved into that space. So you can see that his molars are not so bad. You have good anatomy in the molars, but it's mostly an abrasion and erosion kind of lesions that he had. Though in the anteriors, lower anteriors, he had all his teeth that are worn out, and he has history of RCTs done in these teeth. So the dentist he went to didn't plan well, or maybe the patient didn't want any kind of treatment and want only symptomatic treatments. So he had RCTs done, which were all failing. So we had to redo, and these lower anteriors had large lesions and with a very, very short root. So we redid all the RCTs because we wanted to grow the bone over there, because this was a little longer treatment. We didn't want to lose any more bone. And once we finished with the ortho, we did a trial smile. That's his trial smile. And this is how it looks. So the plan was to remove those lower anteriors, the 4 anteriors, we extract them and place implants there, and still restore the canines with post and core. So this is what we achieved. Of course, we did a little bit of redid the vertical height a little bit. We didn't do anything on the lower molars on one side. And this is the prep, very, very minimal prep. We kept everything in the enamel, and except in these areas where you can see the margins are in the enamel, we had very good margins of enamel, but the entire body was on the composite. And you can see this is what we did for him. This is after we placed all the teeth. You can see the laterals, because he's a very small made person with a very delicate face, and we gave him a very delicate lateral with the rounded edges that gives the delicacy to the entire smile line. My last case is the case 5, which I love to show this case, 2014. Patient came with sensitive teeth. you can see a lot of acidic erosion. I wouldn't call it, the attrition. I would call more like an acidic erosion. You can see a lot of dimpling of the teeth over here, and there is no attrition. You can see all the some craters over there. So the patient came in. We did full mouth rehab. I took this case up for full mouth rehab, and you can see some spots over here. A very nice patient. And this is what we see. Again, all minimal preps. These are all veneers. And 2016, this is what you see. And this is what you see now. So you can see how well stable your teeth are. You can see some stains over here. He's a green tea drinker, so you see a lot of stains in those areas, but he's caries free. Very good. You can see some changes over here too. It's many years. It's almost 6 years since he has used his teeth. So you can see here. And say we have done crowns because you could probably, if you remember the image, the first image, he had a lot of caries in the anteriors, proximal caries, and this is how he looks today. With that, I end my presentation. Thank you so much for your patient hearing, and I think we are on time, and I would like to take some questions. Thank you again, Dr. Pratima Shanai and your team for giving me this opportunity to.
Hello.
Yes.
Simply superb, madam. It was really a great presentation and will definitely help us in recreating beautiful smile.
Thank you.
And now request Wala madam to please deal with the question answer sessions from the participants. Kundawala madam. Hello.
I think we have lost her.
Hello.
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 Somebody
Kundawala
has
madam.
muted me. Muted. Unmute me.
Over to you for question answer session.
Yeah. Have you unmuted me?
Yes.
Okay. Because I'm not able to unmute me. That is why. Okay. Thanks a lot, Dr. Jayshree, for that excellent presentation. And can you take up questions now?
Sure.
Dr. Majumdar wants to know what kind of ceramic veneers were placed. What was used for thin veneers? Which material was used for thin materials? And
I use Emacs itself. That's my always, that's what I use. My, for the anteriors, if I have to really tuck them in, I always use, I don't overlap the incisal edges in the front anteriors. In some cases I do, depends on the cases. But for the canines, I do give a thin lingual shoulder on the incisal edge. So I overlap the canines, but laterals and centrals, I give a butt edge.
okay, Dr. Konar Patil wants to know what is the protocol of bonding.
Most of the cases are in the enamel, and you got to etch the enamel 20 seconds. Then I use, currently I'm using Variolink's tetric end bond universal. In the past, what you see at 2011 cases, 2014 cases, I used to use the 3-step Syntec, 3-step, where you etch, bond, and you put a self etchant and 3-step bonding system. But now I'm using a tetric end universal bond. So I use the universal bond, 20 seconds, you got to rub it for 10 seconds, then another 10 seconds, you allow it to settle, dry it nicely and cure it, light cure it, and then place your cement, that is your Variolink aesthetic, onto the veneer. Use a nice little probe or a temporary or a plastic instrument to nicely spread it so that you don't get your air bubbles. You place it on the tooth, vibrate it slightly. You can use an optostick to take the veneer because it's easier to carry that veneer with optostick. Place it on the tooth. Use your floss. Make sure that you floss the interdental space. A 3-second cure on all the angles, and starting with the incisal edge first and then the angles of the tooth. Remove all the excess, place your glycerin, and then cure it. Final cure.
Okay. Somebody wants to know, what about on luminaries?
I personally not used luminaries, so I can't say much. I'm sure it all depends on your bonding protocol. Doesn't matter how thin your veneers are. It all depends on how well you bond it to the substrate and what is the substrate material that you have. It's the best bond is enamel, followed by dentin, and then the composite.
Somebody wants to know, Manjunath Mesta wants to know, which material do you use for bite registration?
I have JetBite. I use JetBite, which is a Coltine product. I've been using JetBite, which is very good. It's very rigid.
Okay. Dr. Purbi Edber wants to know, what is your take on incorporating elements of visagism in treatment planning?
That's not bad too. You can do it. It requires some time. So if you have the time, you can incorporate many things, especially even the digital, smile designing, but it requires a little more time compared to what I'm doing right now, but they're all very good things to incorporate. But I didn't have much time to discuss all the different aspects, but I think for 1 hour, aesthetic dentistry by itself is a very, very big topic. We can discuss it separately as a topic, but it's a good thing. I approve, and I think it's a good thing too.
Yeah, I realize, because it is very difficult to explain about one aspect of a smile designing. So the whole smile designing will be very difficult.
Yes.
So what is the protocol for selection of shades for anterior teeth? Do you use any shade matching devices?
So if you're doing only the upper anteriors, then it's very critical for you to match the lower teeth. But if you're going to do the anterior entire segment, you can always choose your own shade and you can ask the patient. And AMAX has this multi shade ingots which are available, that is polychromatic. If you say A1, it has a very nice transition from the gingival to the incisal edge. So if you like A1, you have to tell your ceramist to use that multi shaded ingot. So you have to tell your ceramist what kind of ingot to use. It's very, very important, because your shade, sometimes even if you give a shade that is a very good ND2, that is a stump shade, I always place it on a gray card. I think in one of my images you could see that I place the stump shade and a C shade and the shade that I want to achieve on a gray card, and I take a photograph, and then send it to my ceramist. But sometimes when you do a very thin prep, And if you have a fractured incisal edge and you want to do a very, very thin veneer, you don't want to remove too much of your tooth structure, but the transition line of the fracture line can be visible. So in those cases also, you have to inform your ceramist not to use high translucency ingot. It's always good to work with a medium translucency when you have some kind of defect under the tooth. If you have very good tooth, like the young girl whom I did, where I changed certain things, there you have very perfect preparation, perfect teeth, substrate is very good, then you can always use a high translucency, but otherwise you should use a low translucency. And the shade that I always use is if I'm using camera, that is, I can use a gray card. Digital, now the digital imaging now has picks up the shade of the tooth in the adjacent tooth. So you don't need a shade guide and shade thing. You have scanners that will pick up the shades.
And last question from Purbi. Treatment approach for midline diastema with active pathological tooth migration.
Pathological, first you got to treat that. Pathological tooth migration. So if you're going to a diastema closure, if the diastema closure is just less than 1 millimeter and you have good sized teeth, that is your laterals are good, then you can still do a composite restoration. But if the diastema size is very, very, very wide, more than 1 millimeter, and you have a very large central incisor, a very small lateral incisor, then it's good to work from canine to canine. So it all depends on what is the space and what is the size of your teeth in these segments. So if you are just planning to do only diastema closure for the anterior central incisors with very large tooth, it doesn't work that way. You have to see how they stand in the anterior segment.
Okay, I think before some more questions pop up, I would like to appreciate Dr. Jayshree for clearing many doubts, and some of her highlights of her lecture I would like to stress upon. I like the multidisciplinary planning of this smile designing with the periodontist and orthodontist, and you have to give them importance, but at the same time you dominating to give the best smile.
Yes.
Because at the end, what you want to give it to for your patient is more important than
Yes.
And then dental aesthetics in relation to oral aesthetics. So oral aesthetics involving occlusion and periodontal health. Those things are also very important. You have highlighted on that. And how to maintain the health of the gingiva first and then treating for long-lasting smile design. And to improve the confidence of the patient by stages in the treatment planning. That is one of your cases. I think you did it in stages. And what patient wanted at the end you could achieve. So that is really appreciable. And we could see the different aspects of smile designing in that case. And communication with the lab. You have highlighted on the communication with the lab and creating corrections in the smile designing just by incisal adjustments. One of your cases, you have just shown a simple incisal edge corrections has shown the design, and gingival zenith corrections, how it is important for, with the very simple gingival zenith correction, how you could change the smile. Only sad thing what about your presentation is you have told elderly patient above 50, and we are all above 50.
So we have more visibility of the lower anteriors.
So we have not yet reached elderly status.
If you actually see me talking, probably my lower anteriors are also more visible than the upper anteriors. Yeah. But there are times when these are all cases that has veneers in it. But I must say, sometimes just the perio and ortho, the patient's very happy, and then we just do a little enameloplasty. We have some cases where we just did incisal edge correction with your discs and changed everything for the patient, where there was absolutely no restorations required. So we have done a lot of cases just doing the enameloplasty, and we have lost a lot of money with that though, but patients very happy with just enameloplasty. So there are different ways of achieving. It need not be always a restorative perspective. It can be only perio, ortho, and just a little bit of enameloplasty.
So just like to add something about lumineers, somebody wanted to know about lumineers. Basically, lumineers are, you know, a thin layer where you want to change instead of bleaching. It's the next version of the bleaching. Maybe you can read upon more on it, because this is not the forum. I think it is Dr. Jayshree also is done with all her cases.
The lumineers is a very, very thin veneer where you can use a light cured resin material to bond the, it's all in the enamel. Sometimes you don't do any prep, you just etch it and you just give a no prep margins, very, very shallow, very thin margins. And that is only to enhance the color of the, I mean, not enhance, just the shape of the tooth, not much to do with the color. If you have to enhance the color, then you need to have slightly conventional veneers. Your lumineers are very thin, where you enhance, where you improve the shape and alignment of the teeth.
We really appreciate for such a beautiful presentation with a lot of clinical tips. What you have given was very useful for us.
Thank you.
I'll thank on behalf of all the participants. So once again, I thank you, Dr. Jayshree, and I thank the organizers for giving me the opportunity for moderating this session. Thank you, Dr. Pratima and her team, and for Dr. Chetna for giving me guidance to handle this and the questions which you have sent for reading. Yeah, thank you from my side. Yeah.
Thank you, madam. Thank you.
Thank you once again, Jayshree madam and Kundawala madam, for an enlightening and truly informative session. Now I request our moderator for today, Dr. Now on behalf of Department of Conservative Dentistry and a certificate of appreciation to our speaker, Dr. Jayshree Hegde and Dr. Kundawala madam. So thank you, madam.
Thank you.
We are also conducting a mask
Selfie with mask
contest. Here you can see. So kindly send your entries for the same before 25th of July. And here are the now we would like to show a few of the entries. This is the entries. So I request all to gear up and to send your unique selfies with innovative ideas of wearing masks. So, apart from the indoor academic activities in this e-fest, we wish to highlight those individuals in our specialty who have enriched their lives with other co-curricular activities as well. We as a specialty have a constellation of endostars in our galaxy. Let's take a glance at one of them.
We have a dashing personality. Dr. Darshan Dakshin Das, who is currently as Associate Professor at GDC Nagpur. Apart
Apart
from
from
renowned
renowned
academician,
academician,
he
he
holds
holds
many
many key positions at MUHS Nasik. He is the youngest member nominated by Government of Maharashtra in Dental Council of India. Dr. Darshan is a lawn tennis player and has represented school, college, and state in various tournaments. He has won 8 singles and 4 double tournaments and is also winner of first Khasdar Krida Mahotsav tennis tournament of Nagpur. He is the recipient of Krida Bhushan Award for tennis from Government of Maharashtra. Dr. Darshan has been selected as Mr. Nagpur in 2002 and also participated in Gladtrax Manhunt, Mumbai. He has done photo ad modeling for more than 75 companies, including LG, Samsung, Nerolac, SBI, Hitachi, and Kesri. So here is a small video. So today we had Dr. Darshan in our Endostar Galaxy. Now I hand over to Dr. Pratik for vote of thanks.
Thank you, Dr. Chetna Makde, ma'am. On behalf of our Department of Conservative and Endodontics, I extend heartfelt gratitude to our eminent speaker, Dr. Jayshree Hegde, ma'am, for sharing her expertise on the smile designing procedure. I would also like to thank our chairperson for today, Dr. Kunnawala, ma'am, for sparing their valuable time. Thank you, ma'am. Uh, Thank you to all senior faculty members and participants for joining us today. See you tomorrow, same time, with the new topic on Zoom platform and also on Facebook Live. Have a great day ahead. Thank you very much. Thank you all.
Now we would end the meeting.